Hello, I'm Tony DeMaria, the editor of JACC, and I'm here with Spencer King, who's many things, among which is the editor of JACC Interventions. And we're here in Amsterdam on day 2 of the European Society of Cardiology meetings, where there have been a number of interesting, I'll use that word interesting, studies. Spencer, the PURE study that was presented about the incidence of cardiovascular disease relative to risk factors in high, middle, and low-income countries.
Yeah, well, more and more there's interest in global health and global cardiovascular risk, and important was made very clearly that most of the cardiovascular mortality in the world is in low-income countries because most of the people are. This study tried to look at risk factors, a whole host of risk factors, and concluded that they're really higher in the high-income countries, certainly things like obesity and so forth, but the cardiac mortality remains higher in low-income countries, suggesting that health care is important. Certainly these are true. There must be many things that go into this conclusion, but I think that it's worthwhile to try to study the worldwide impact of cardiovascular disease.
Yeah, no question that non-communicable diseases are becoming much, much more important in the third world. My impression of this study was that there were a lot of potential confounding variables. Age, for instance, as a cardiovascular risk factor. If life expectancy is lower in the third world, they're going to have less risk factor just on that basis. So some interesting data that need to be dissected out. A couple of important trials FDA mandated on new oral hypoglycemic agents for diabetes.
Yeah, one of them is the EXAMINE trial, which showed allogliptin tested in acute coronary syndrome patients. So this was perhaps a higher risk cardiovascular population. And bottom line is that they did not show increased cardiac risk. Rather neutral trial in terms of the drug, which was lowering the hemoglobin A1C and so forth, but did not adversely impact cardiovascular risk. And the other trial is the SAVOR-TIMI 53 trial, massive trial, 16,000 patients of another drug, which is a
I think it was saxagliptin.
Saxagliptin, yeah. And that, again, was a safety trial to show that it did not increase cardiovascular risk, and it did not increase myocardial infarction, which was mainly what they were looking for. There was a slight increase in admissions for heart failure, which was not explained in the presentation exactly what that meant. Maybe it needs more study.
Yeah, I thought these were interesting trials. They were FDA mandated on the gliptin drugs, allogliptin and saxagliptin. And from one perspective, given the concern on the rosiglitazone and pioglitazone agents, one could have looked at this and said, well, this is reassuring information that really in these cardiac patients or at-risk patients, there was no increase of hard cardiovascular events. From that standpoint, it was reassuring. Unfortunately, there's still no evidence that the more rigid control of diabetes will reduce cardiovascular events. They lowered hemoglobin A1C but didn't reduce cardiovascular events. And I think we're going to have to be careful in using these drugs in patients who have heart failure so that we don't decompensate them.
Sure. The other trial that quite interested me is the SURE trial, which was an ApoA1 inducer trying to raise HDL once again. So we've been around this a few times, but what did you take on that trial, Tony?
Well, this is an agent that it's not one of the CTEP inhibitors that have been used, dalceftib, torceftib, et cetera. This is a new agent that induces an increase in apolipoprotein A1, which is the major lipoprotein in HDL, but it was kind of a weak increase or inducer. only a couple of percentage points increased HDL, only to about 10%.
Yeah, both groups increased, the placebo and the experimental drug, but the difference was 11% for the experimental drug and 8% for the placebo. So it sort of failed to achieve much of a HDL increase.
Yeah, so it wasn't surprising that in failing to increase HDL very much, that it failed to change plaque size, because IVUS was the primary endpoint here. So you could look at it another HDL failure to benefit by increasing HDL, but the search will continue for some agents that could potentially be a little bit better. Now, in contrast to that, the COMPARE trial I thought was pretty interesting and yielded some positive data that maybe will influence patient care.
Yeah, I think this is the one this morning that really caught my attention. Marfan's patients have enlargement of the aorta over time, as we know, and this study was the first one that I'm aware of that showed a drug that would inhibit that, and that was Losartan, a very inexpensive, commonly available drug that was given to patients in a randomized fashion, though in a 3-year follow-up with MR adjudication of aortic size. 27%, I think, of the patients had surgery with a root replacement and so forth. The rest did not, but they measured the aortic expansion. It was dramatically less, almost half the expansion compared to placebo. So it looks like we've got a drug that may be very useful for Marfan's patients.
Yeah, there's been anecdotal evidence, small data, that Losartan could be effective in Marfan's patients in reducing progressive aortic dilatation. But this is the first randomized prospective data, and as you say, it more than halved the rate of aortic dilatation, and also prevented aortic dilatation about 50% of the patients. So I think based on these data alone, and given the fact that Losartan is a time-tested agent, that probably it would not be unreasonable for Marfan's patients to begin to take this agent.
Yeah, sounds quite positive.
Yeah. So lots of studies here, lots of new data at the ESC in Amsterdam. We'll be back this afternoon with some more late-breaking clinical trials.